need to think about for your cardiovascular patients. So we're going to talk about hypertension, coronary heart disease, the dysrhythmias or arrhythmias, congestive heart failure. Actually, I don't think congestive heart failure is so much in there, but it's, yeah, it is. Congenital heart disease, which can include the valvular defects and possibly surgeries that people have to take, have to have for valvular defects. Rheumatic heart disease, just a tiny bit, smidge. It can get a little confusing there in that part. So we'll I'll try and be very specific there. And then infective endocarditis, which you might have also heard of as bacterial endocarditis or subacute bacterial endocarditis, but pretty much the umbrella statement that as infective endocarditis, and we'll talk about why that is. And okay, so in general, what's cardiovascular disease? It's the alteration of the heart and or the blood vessels, and it impairs the function somehow. So your heart is not working properly, and there's several different things that can be going on. That's the different diseases that we'll highlight. It is the leading cause of death. Last time I pulled this figure, 45% of deaths worldwide. It does seem like there's more stuff going on recently with cardiovascular problems in general. So it'd be interesting to see if that figure changes. But last time I pulled that figure, it was 45% of deaths are attributed to cardiovascular disease worldwide. Management of it, lifestyle, medications, these things are very important. If somebody knows they have a family history, it's very important for them to know how to manage these risk factors. Cardiovascular disease and periodontal disease share several risk factors. So this is important to note. Patients with diabetes are at higher risk for cardiovascular disease and higher risk for periodontal disease. Patients who smoke obviously are at higher risk for both. Elderly patients are going to be higher risk for both, and people in a poorer socioeconomic conditions or status are going to be at higher risk for both. Chronic infections from periodontal disease may increase the risk of cardiovascular disease, but that research is still sort of being done. They know that there's something correlated, but they, like with diabetes, they absolutely know that bidirectional relationship question. They absolutely know that out of control diabetes and out of control periodontal disease just are a vicious cycle that affect each other. So that is absolutely proven. They suspect that perio and cardiovascular disease may be similar, but it's not proven that there's a causative effect. There's just like a correlation there. So that's kind of important. The research is, they're still doing research. So risk factors, there's modifiable risk factors, and then there's non-modifiable risk factors, and then there's this sort of little gray area that's the disease patterns. So if somebody has had a severe eating disorder, they potentially possibly could have had some heart damage. That's not to say that they do, but they possibly could have. And then back in the day when they were prescribing fen-phen, that could have also caused heart damage. So those are some disease patterns that could affect it, but non-modifiable, obviously it's how you're born, with your genetics, you can't change your age once you start aging, and race and gender. So those things are non-modifiable, but modifiable would be lifestyle, other conditions that you have that you can either get under control or out of control, tobacco use, and the things like that. And then periodontal disease is there just as another thing that if somebody has uncontrolled uncontrolled periodontal disease, a lot of times it can harken to other systemic diseases that might be also not in control. People that are highly stressed, workaholics, or people that just don't deal with their stress well can also be at higher risk. For now, it'll be fine. Deep breathe. Our first SADA meeting, we'll get some tools on how to deal with our stress. So hypertension, so what is it? We talked about that persistent elevation of systolic and diastolic blood pressure from just, the either too too much fluid going through the vessel, or sort of the vessel being rigid and just not being as pliable. Hypertension is not actually considered a disease. The textbook says this, it's more of a physical symptom or a finding. And there's two kinds, there's primary and there's secondary. So primary, sometimes it can be caused and they don't know why. Like someone just starts to develop hypertension. Secondary is usually is specifically related to a disease. So if somebody has a specific condition and then they know hypertension is sort of something that can show up because of that. It's important when you're looking at this chart here to see this and then the or. So once somebody hits stage 1 or pre-hypertension, it doesn't matter if it's elevated, if they're like within this range, like 82, or, they could be 130 over 82. Or no, I'm sorry, I said that backwards. So they could be 130 over 79 is what I mean. And so they only have to be one or the other. But if they get into this orange range, even if it's not both, they're still considered a stage 1. So patients with hypertension, they should be screened. That's why we do a screening. That's what we do when we take our patients' vitals. So that's really a helpful thing. They take it at their physicians, they can take it at the pharmacy. So it's good to do the screening, monitoring, and then for patients to understand their risk. So sometimes patients like never, you can get somebody, I've had patients in my chair, like a 55-year-old guy that's like a workaholic, and he comes in and I take his blood pressure and it's really high and he's just like, oh, I feel fine, and they just never notice it or think about it. So it's good that we do that screening and we can kind of help educate patients a little bit. So the drug therapy, this harkens back to our oral med days. We know the different categories: the beta blockers, calcium channel blockers, diuretics, ACE inhibitors, and the ARBs. It's pretty much the book, Darby and Walsh divides it this way into the 3 different types, which is kind of nice to think about it this way too. Diuretics, it's gonna remove excess fluid, something like your HCTZ, hydrochlorothiazide. Sympatholytic agents, they modify the sympathetic nerve activity, so that's how it controls the blood pressure. And so that would be something like your lisinopril. And then vasodilators increase the size of the vessel, and that would be something like minoxidil, which is also, I believe, Rogaine if it's used topically, which is, I always find that interesting. Drug therapies, there's certain things with the high blood pressure medications are very, very prevalent. Many of your patients will take them. So just being aware of the orthostatic hypotension, the increased urination, the xerostomia, and the gingival enlargement if they're taking a calcium channel blocker. And also how if they take, a lot of times we'll tell our patients like to take ibuprofen or NSAIDs because of the anti-inflammatory for pain medication, but just remembering that that affects their blood pressure medication. So it's not always the best thing to actually recommend. If somebody has uncontrolled high blood pressure, we have to follow our clinic guidelines, then you're going to postpone treatment. In general, this is like a mainstay to a lot of these conditions: short appointments, reduce stress. The best time for the patient, this doesn't specifically say morning appointments, but very oftentimes people just do better in morning. But this, like it's not designated that, but in general, keeping appointments shorter for the patients and helping with pain management, because again, just like what I said with the diabetes, epinephrine is endogenous. If they're stressed out, they're going to make their own epinephrine. So keeping them comfortable and reduce their discomfort. But if somebody has higher blood pressure reading, you may choose to use mepivacaine. And in general, if somebody is any kind of an out of control cardiovascular, it's usually capped at 2 carfules. That's just a rule of thumb. Yeah, Shandy.
What can we recommend for them for pain other than ibuprofen or NSAIDs that they're going to have?
Probably Tylenol, I would assume. Yeah, would be probably the best. And they may, yeah, I would say Tylenol.
And that's, they can get a few minutes and.
Yeah. And then of course, always just the physician is always available to call if you want to clear up any of these issues. Even if you have a patient in our clinic or when you're out in practice that they're like, oh yeah, it's fine, but you just feel unsure about something, they just don't seem as controlled or healthy and you're just uncomfortable, you can always reach out to physicians and ask. So here's our new, I think this is the updated, I pulled this from the manual, the clinic manual. So without comorbidities, 180/110, but with comorbidities, 160/100, and then hypertensive crisis, 180/120. So we'll talk about coronary heart disease. And this includes disorders such as atherosclerotic heart disease, angina pectoris, coronary insufficiency, and a heart attack or myocardial infarction. So it's a couple under this umbrella. So it's insufficient blood flow from the coronary arteries to the heart or the myocardium, the part of the heart muscle. And again, these are the conditions, atherosclerotic heart disease or arteriosclerotic heart disease, I think is the bigger term. And then atherosclerosis falls under it. It basically is talking about the arteries, but they're named slightly differently. Sometimes people use them interchangeably, which can be a little bit confusing. I think a lot of times we refer to atherosclerosis, but that's technically the plaques building up in the vessels is atherosclerosis. So a major cause of atherosclerosis is of course narrowing of the lumen, reducing the blood flow because of the plaques or the fibrofatty substances. So angina pectoris, so what is that? That's inadequate oxygen flowing to the heart. So the goal when somebody is having an angina attack, the goal is to reduce the demand of their heart for the need for oxygen. So help them relax. If they were walking upstairs, they have to sit and rest a little bit. If they're in your chair and they weren't like doing anything really physical, but if they're feeling stressed because of something like, you just gave them, you just started SRP or something like that, then you just help them kind of calm down, but also they will use their nitroglycerin, which acts as a vasodilator and opens up the vessels. So that's what they're going to reach for if they're legitimately having an attack. So DH appointments things as a dental hygienist to be aware of is to reduce the stress for your patient, identify the condition and the frequency. So ask your patient, how long have you had angina? How is it stable? Are you there is stable and uncontrolled angina. And generally speaking, you wouldn't see somebody in your chair likely who has uncontrolled or not stable, but you want to kind of find these things out, talk to your patient about their condition. How often do you have to take your nitro? Do you have to take it pretty frequently, or, oh no, it's been in my purse for 8 months, so you can ask them these questions. Ask them if the condition has worsened or become more frequent. And then you want to make sure that they have their medicine. And then on top of that, you want to make sure that their medicine is fresh, because if it's been in their purse, for 8 months and they've opened it, then it's not going to be very potent. And so you want to know about it. If it's a brand new sealed thing, like that, maybe it lasts longer, maybe they know about it, like, no, this is something that lasts until I open it and I haven't opened it. And, so maybe it's a different product, but in general, if they've opened it and used it and it's been more than 6 months, it's not going to be as potent. So the other thing you want to be aware of is this medical emergency. And I know you guys learned this with Monica, but just to review, you give your patient, they say, I'm having an angina attack. They take their first dose. So they take a dose, you wait 5 minutes. That dose doesn't seem to be working. They take another dose, you wait 5 minutes. That doesn't seem to be working. They take a third dose. You wait maybe not 5 minutes, but you say, okay, is that working? If it's not working, you call 911.
I think on the third.
Is that what Monica said? Okay, that's not what they say in Darby, but if that's what Monica said, then go with that. Mm-hmm. So that's fine, yeah. So 3 doses max, and then you'll call EMS. So, and then, so I think that's all there was for angina. So then for myocardial infarction or a heart attack, so what's happening there? There's obviously no blood has gotten to an area of the heart, and then there's some kind of an infarct, which is tissue necrosis. That part of the heart is dying because it's not getting any oxygenated blood. So for those patients, there's different things out there for myocardial infarction. Some will say 30 days after their heart attack, if the patient is stable and they're feeling good, and maybe it was something that doesn't have a lingering, maybe it was some kind of an electrical issue. Because you can have a heart attack because of like an electrical issue in your heart, or you can have it because it's like there's been a clot or, there's something clogged or something. So there's different reasons that someone might have had a heart attack. And if they're healthy and it was some issue, they'll tell you about it, then you may be able to see them after a month, after 30 days post MI, as long as there's no risk factors or complications. But that again is something that you talk with the doctor that you're working with, and you also talk with the patient, and you may very likely call their patient. If they're in your chair after 30 days, I personally would call their doctor. That's what I would do. Wouldn't take their word for it. If they were like, I'm fine, I'm like, well, I just gonna check with your cardiologist because it covers your own butt, so that's what I would do. But so then there's other information out there. The one practice that I worked for, we wouldn't see anybody, it had to be 6 months post a stroke or a heart attack. And that was the doctor's preference. So that's why I put up there, other sources state 3 months, some sources state 6 months. So you're just gonna have to, there's not like a hard and fast rule. Yeah.
When we're out in practice and we do get a patient in our chair that has had a heart attack maybe 2 months ago, and that's comfortable seeing that patient, and we give their doctor a call, what is the timeline to get any information from their doctor without having to like request information to be released? Can they just call us over the phone?
Yeah, usually like you can have a conversation with a doctor over the phone if they're available. And I know nowadays, like I can't even imagine how there's so many, I could barely get a form filled out at Kaiser for my daughter. I couldn't get a doctor on the phone with Kaiser. Like, I could after, sitting on the phone for a long time, but as a clinician with a patient in your chair on a very tightly packed schedule, I think that it's going to be trickier. But if you can say something like, I have a patient in my chair now, and I need to know now if it's okay if I can go ahead with treatment, you might be able to rush it. But if you can get a doctor on the phone, you can talk about the patient over the phone. That's okay. So it's just getting them on the phone would be the hard thing. The other thing would be, reaching out to the office, and then, the doctor will call you back. Well, I might be with my next patient. So a lot of these kind of protocols, there will be something set up in the office that you work for, and there'll be a way that the dentist typically handles it. And if something is coming outside of your comfort zone, like the doctor is pushing that it's fine for you to go ahead with treatment, but you're uncomfortable, then those are just topics you have to talk about with the doctor. But a lot of times there are sort of protocols. Like that one doctor that I worked for, she was like, they have to come back with a note from their doctor that they're cleared, or 6 months pass. Like she was really rigid about it, and because she didn't want a medical emergency in her chair. So sometimes that's what you find out in practice, which is kind of nice, because then you don't have to worry about it so much. So drug therapy for somebody who has had a heart attack, they might be on an anticoagulant. They might be on digitalis or digoxin is the more common term. That strengthens the contraction of the heart, or they are very likely taking an antihypertensive medication. So this is pretty much saying a little bit about what was said in the last slide, except for pain control. You can do nitrous oxide if there's no other contraindications that the patient has. And sometimes, sometimes that can help. Oh my word, where'd I go? Sometimes that can help because, again, feeling stress or pain is not good for the heart either, especially if they have a heart condition. And then you want to talk to them about lifestyle changes, the oral systemic relationship. You can, if you can't see them in the chair because of, they have to come back, you need a doctor's note, at least you can talk to them about some of these conditions and how the health of your mouth affects the overall health of the body. So dysrhythmias and arrhythmias, what are they? So these terms are a little bit interchangeable. In general, if you're talking about a dysrhythmia, you're talking about a diseased heart. And if you're talking about an arrhythmia, it could potentially be more just like something like an emotional state or something that's caused from physical stress. So I don't know that again, that's not necessarily hard and fast. They did, the book does say that they sort of sometimes are used interchangeably. But those are sort of two ways that some people differentiate them. So it's a dysfunction of the heart rate and the rhythm that manifests in heart palpitations, disturbances of nerve impulse formation. And probably everybody here, has everyone felt their heart flutter, especially if you're stressed? When I was pregnant, it happened a lot in the beginning, and then it kind of settled down, but it's always kind of weird. It's like, oh, there's butterflies in my chest. That's odd. So it can be a little bit disconcerting. So you can get it from physical or emotional stress. There's a couple different heart conditions that can also manifest it. Drug toxicity can do this also, or electrolyte imbalance. So somebody that is, if somebody is maybe has an eating disorder, or they just haven't been taking good care of their body because they're just not paying attention, or they've worked out and gotten rid of a lot of electrolytes and they need to replenish them. So different various circumstances could affect it. To get a diagnosis, you need to either have an ECG or an EKG, an electrocardiogram or an echocardiogram. And that's usually done in the hospital or the doctor's office, but they also have monitors that you can take home, and you can wear one for 24 hours or 48 hours or whatever it is. There's a couple different terms here that I thought you should be familiar with. Bradycardia, Brady slow. You've learned that from other classes with using that medical term. So bradycardia is decreased heart rate or heartbeat decline to less than 60 beats per minute. Tachycardia, increased heartbeat greater than 100 beats per minute. Atrial fibrillation is rapid, uneven, irregular contractions in the upper chambers of the atrium due to irregular impulses. Premature ventricular contractions that pause in an otherwise normal rhythm. So there's just a little pause there. And then the ventricle fibrillation, you guys know that's the bad one. That's just your heart's not even pumping, it's just fluttering. So no blood is being pumped out of the heart. And that's lethal if it's not addressed in a matter of moments. So that's the really bad one. And then the heart block is kind of, the book doesn't, there's a little bit more about it in the notes here that I have, but it's interference of electrical impulses controlling the heart muscle. So something is blocking normal heart electrical impulses. Okay, so nowadays, and what's his name that does the CPR? Brad, he addressed this a little bit when he did our CPR. We're talking when you're using the AED, if you see like like a big lump, that's a pacemaker. But he was saying how nowadays pacemakers are actually very small, and you don't see like a big scar and a big lump like you used to. And it's the same thing with the non-shield or the shielded. I'm not a heart surgeon or a cardiologist, so there's probably something I don't know, but I can't imagine nowadays that there's anybody who puts a pacemaker in somebody, they're not putting in a shielded one. I just feel like that's something like, but you may have an elderly patient, you may see someone in their 80s that has a pacemaker that was put in a long time ago. So it's still relevant to be aware. And then you also think about our clinic, if we have chances are there won't be 16 ultrasonics going, but if there's, you know, a lot of ultrasonics going and other electrical equipment, and they have an unshielded pacemaker, that's potential for interference. So with a patient, if they have an unshielded pacemaker, you can have them put a lead apron over their chest while you practice on them. And that's fine. If something starts to happen, if their pacemaker starts to malfunction, they're going to feel these symptoms: difficulty breathing, dizzy. There's going to be a change in their pulse rate. So if that happens, very likely you'll probably just want to call 911. That doesn't seem like a situation where, oh, let's just wait and see if you feel better. I mean, that just feels like something you'd want to address right away, but also turn off if there's any ultrasonics around in the, you know, the bays around, turn any kind of electrical interferences off. Let's see. So for cardiac dysrhythmias and arrhythmias, you don't need to pre-med, even though they've had surgery. They've technically had, you know, like some surgery in and around their heart. You don't need to pre-med. You do want to consider the drug therapies they may be on. They may be on digoxin. Like we talked about, the shielded and the dental equipment, recording their vitals, and then monitor patient throughout the appointment. Any patient who has a systemic condition, you always monitor them. You always check in with them. You always see how they're feeling and how they're doing, if they have any concerns and that sort of thing. That's just part of practice that becomes very routine. So with congestive heart failure, the syndrome characterized by myocardial dysfunction that leads to diminished cardiac output. So the heart's just not pumping effectively. Or there's an abnormal circulatory congestion. So things like tachycardia, ventricular dilation, enlargement of the heart muscles are all things that can be present with somebody who has congestive heart failure. And then the etiology can be from atherosclerosis, hypertension, valvular disease, pericarditis, circulatory overload, or coronary heart disease. So congestive heart failure can have several elements to it, basically. Medical treatment, if there's something that they can remove or fix to improve their condition, then they'll do that. Dietary control, sodium, usually, like reducing sodium, reduced physical activity. Sometimes they just can't be as physical. Somebody that has congestive heart failure, they struggle going upstairs. But so then they'll also be on drug therapy like diuretics to reduce the excess fluid, and also digitalis to help increase the contraction of the heart. So they're going to be closely monitored by a physician, because this is, you know, needs a lot of monitoring. Their medications need to be adjusted. They may have other things that are going on, you know, like the fluid retention and the coughing, and, you know, different things that could be happening, especially if they're pretty severe. So they're going to be under close monitoring from their physician. If they come in and they're really stable, there's not a lot that you have to do. But I was going to take that out, because I'm like, I don't like that, because there actually usually is something that you want to think about. Like, you always want to think about their blood pressure. You want to be more aware. So as far as alterations, I scratch that. I'm gonna next time I get in my office, I'm gonna just take that out. So when I was reading that last night, I was like, I don't like that, because that makes you think that that's just a patient that can come in your chair and you don't have to think much about it. But someone with congestive heart failure, you actually do want to be more alert and aware. Especially if they're going to be taking medications for hypertension, or for any of these other things like the valvular heart disease or coronary heart disease, or if they've had a heart attack. So there's just more things to keep on your radar. You know what I mean? That just makes sense in that way. Also, if they're taking digitalis with this more susceptibility to GI issues or the gagging, and then also the difficulty breathing, a lot of times they might cough a lot, or they might not like to be laid back all the way. So you might have to put them in a semi-supine position. So that certainly is alteration. So I'm going to take that out. And then you minimize stress and discomfort. They may not be able to tolerate the ultrasonic because of just the flow of the water, especially if they do have difficulty breathing. And then nutritional counseling. Air powder polisher, we don't use them very often, and you may not in practice, but if you use an air powder polisher, there's sodium bicarbonate, which, would be pretty much contraindicated for somebody who has congestive heart failure because they might be on a reduced sodium diet. So just to be aware of that, although not a lot of hygienists use air powder polishers, but they could come back into bad, you never know. Congenital heart disease. So this is going to be an abnormality of the heart or the structure or the function from birth, so before birth, so when it was developing. So a lot of times people with congenital heart defects are going to have undergone some kind of surgery. They may have something in their heart that requires pre-med. So this is where your red flag will go up a little bit more for pre-medication. Residual defects following a repair. These are things, people who may end up needing a pre-med. If there's a residual defect, if there's a palliative shunt, or if it's been relatively soon after surgery. So if they had surgery within 6 months. And again, this is something you would want to clear with the physician. If they come in and they give you their health history and they're like, oh yeah, I had heart surgery like 5 months ago, but everything's good. And it's like, well, did your doctor say you needed a pre-med? No, I don't think they told me that. Well, then you want to clear that up before you start. So that would just be like, well, we have to get a clearance from your doctor. And then and that will probably mean that they'll have to reschedule their appointment because it would be hard to get them on the phone. Although you may be, depending on where they go, you may be able to get their doctor on the phone. But that happens. Or if people forget their pre-med, sometimes the doctor will hand out a pre-med in the office and actually give them the medication. But sometimes you have to reschedule them. It just depends on the office. So management of any cardiovascular complications, such as congestive heart failure or dysrhythmias resulting from the defect. So again, these heart conditions can sort of affect each other, or they can be layered on top of each other. Consult with a physician about surgeries, medications, overall medical status, and then the need for pre-med. So to clarify all of that stuff. So you don't want to tell them they need a pre-med if they really don't. So you want to, like figure that out with the cardiologist. How did I get through this in 30 minutes last night? And I feel like, I don't even know. It's like, we have 43 sides and we're on 24. I'll give you guys a break in a minute. Let me wait till we'll get through this section and then we'll take a little 5-minute stretch break. I know this is a lot of information. Does anybody do you feel like a little overwhelmed? Yeah. And I'm talking like a mile a minute. I know, it's a lot of information. I would recommend in this class making a table, like a chart, and you put the conditions and then put just the biggest things that happen for each person. So not every little thing, because every patient is unique and every patient can have some funky little thing, but the big things that you want to know if you do that, that will help a lot. That will organize the topics in your mind, and it'll pull out. It's like when you think of a calcium channel blocker medication, you're like gingival hyperplasia, or when you think of seizure medication, you're like gingival. It's just one medicine that does one thing, and it directly affects dental hygiene, and so it helps to simplify it. So I would recommend making, at some point, kind of creating a table to study off of, especially for finals and for the national board. I think those are helpful because I can feel the overwhelmed vibe in the air. I know it feels like a lot of information, which it is. It is a lot of information. Is cold in here? Is everyone else cold? No. Jenny, you're like, well, I'm freezing. Yeah. Okay, so valvular heart defect. So what is that? So cardiovascular damage from a malfunctioning heart valve. It used to be if somebody had, murmur or mitral valve prolapse, oh my gosh, everybody had pre-med. Everyone went on pre-med. That's not the way it is anymore. It's people can have murmurs and they can have a mitral valve prolapse and they don't necessarily at all need to have pre-med. But here are some conditions. It can affect the mitral valve, it can affect the aortic valve or the tricuspid valve. A lot of this information, for example, like these three valves, you don't have to memorize. I'm not going to ask you a question about what valves are affected. You know, it's that runs pretty far from what you need to know for clinical care. Does that make sense? So I'm not necessarily going to quiz you on these little details, but they're in the slide, so it's just information. But I don't want you guys to get too hung up on that stuff because that can stress you out. Mitral valve prolapse is the most frequent. So if somebody has an issue with their valve, it's oftentimes the mitral valve. Prolapses is when it flops backwards into the left atrium and it kind of can cause a little bit of a backflow or kind of a bubbling regurgitation kind of sound. Stenosis may develop, which is the backflow of the blood from an incomplete closure. So it doesn't close nicely. It kind of like flops and does something funky. An echocardiogram or an ultrasound diagnoses this. Commonly associated, so this is where the risk factors for valvular heart disease, it can be associated with rheumatic fever, which that'll be the next thing we talk about, which can get a little weird when the pre-med. It may be congenital, so they might have been born with it, or it can develop after they've had infective endocarditis. People can have infective endocarditis for reasons other than coming to the dentist. We think about it so often in our world because we worry about patients having it, you know, and so we want to prevent it. But they could have developed it from some other exposure, some other way, and then it can cause damage to the valves. So, if they had it in the past. So we want to stress good oral hygiene. We're thinking about the bacteremia, that's the bacteria in the blood. We're thinking about how much bacteria is in the blood, preventing severe bacteremia. So we, of course, want to encourage good oral hygiene. And patients who have good oral hygiene will have less bacteria in and around their teeth and in their sulcus and things like that, and will introduce less bacteria. We know that when they floss and brush, you can have self-induced bacteremia. I mean, if your mouth bleeds when you do, you know, any kind of oral hygiene, that's pretty much doing the same thing, but it's the level of the bacteremia, how much bacteria, and also their susceptibility. So a patient who has had a prosthetic valve requires pre-med. So that should be in red. It's like in dark green, but that should be like highlighted. But a prosthetic valve is like your mainstay patient who needs a pre-med. Regular maintenance, also you'd want to encourage regular recall to keep their mouth healthy, again, because we want to control the level of bacteria in their mouth. Other things to think about for a patient who has a valvular heart defect is, are they taking an anticoagulant? So are they taking warfarin or heparin or Plavix, something that reduces clotting? Then there's these figures. Honestly, I never checked. A few patients had their prothrombin time or their INR on their chart. But that was more for the surgeon. I worked for a periodontist, and so he did surgeries. But as a hygienist, I've never had to think specifically about, I've never had somebody so sick, let's say in this realm, that they were at a high risk of like bleeding excessively from a cleaning. But these numbers are still something that the national board can ask you these numbers. I don't think it's something you're going to very frequently deal with as a clinician, like once a week or once a month, you're going to have a patient and you have to check their INR or their prothrombin time. I don't think that that's something that's going to come around very often, but it definitely is information that can be on the board and that you need to know about. So knowing what's a normal range and where it's okay to treat in case somebody comes in and says, this is my status and my last you know, prothrombin time was 15, and you know, okay, good. Well, I know I can work on you as long as it's under 20. So between 11 and 14 is in the normal range, and then less than 20 means that you know that they're gonna probably clot at a decent time. The INR, the International Normalization Ratio, it's a similar thing, but I think it's just it's international, so it's the system that everybody uses, and normal for this would be 1.5, and then treatments can still be performed between 2 and 3 for an INR. And then you may need to consult a physician to ask questions. These are important things. So these are some things for you guys to highlight for quizzes and exams. So if you have somebody who's taking warfarin or Plavix or something like that, and you're doing an SRP on them, you want to work with, it says one quadrant at a time, or one area at a time, but think of it in terms of like 2 or 3 teeth. So start in the least inflamed area of like whatever molar area that is. So let's just say 2 and 3 aren't as inflamed as 14 and 15 are on the mandible. So start with 2 and 3, start scaling, pause, and just see how they're clotting. So don't like just go to town with the ultrasonic and just go everywhere. I'm just knocking off calculus everywhere, and then they're bleeding everywhere, and you can't really get a good like view of what's happening with their mouth and with their clotting. So just start in the least inflamed area and just spend time there and just assess how they're clotting. So scale one area at a time, begin in the area of least inflammation, periodically check for clotting, and then emphasize good oral hygiene. Because if their oral hygiene is good, and then they're gonna their tissue is gonna bleed less. So they're just gonna be in better shape. Okay, so before we go to rheumatic heart disease, let's take just a 5-minute stretch break. You can get up and walk around. I'm gonna run to my office and get the activity. Hopefully we have time for it. Even no, I think that's it. It's not supposed to be and here's the activity from last week too. You guys pick up. I'm gonna put this up here on the table. You guys can just thumb through it. Yeah, you guys can grab one of each of the activities and then your activity from last week. It's better, yeah. So I'm gonna hope they take You don't have to staple them, you can if you want, but they're different topics. That one's on implants and then that one is the cardiovascular.
Okay.
So they're different topics.
Are we giving them both to you?
Yeah, I'm trying to think how I'm gonna do it, cause I'm looking at the time and I'm not gonna get to implants at all. Cause I want to give you guys, I don't even know, we get done in like 10 minutes. I'm like, so where does the time go? Oh my goodness. So I might have to change, typically I like to have them back, but I don't, yeah, but I don't think that's gonna work out. So I have to do some thinking here. Yeah. Yeah, it's just, it kind of highlights things for you that I'm like, would want you to focus on. Mhm. Is everyone okay down there? Is everything all right? So, okay. So I'm gonna try and get through the rest. This is what I'm gonna do. This is what I'm gonna do. So next week, there's no class and I can't schedule class on a day that there's no class. So which I wouldn't want to do anyways, but what I'm thinking of is if I can go through the implant PowerPoint is there. There's a couple, you have the handouts here. Once everyone comes back, I see that. So, yeah, I'm just gonna have to wait again.
No, those are ugly. Don't buy those. It's our schedule, like, it's a lot, because, this is honestly like, because that's all permanent.
Okay, so there's a few more up here. So you guys can get your activity from last week so that you have your activity from last week. And then when you come up, grab one implant and one cardiovascular worksheet. So Jessica, Denise, Brandon, Madison, Hannah, and Jenny. You guys are. But then there's and then grab one of the worksheets. Yeah, one of these. So what I'm gonna do is I'm gonna post how many people would want me to talk through the implant lecture and then you'll actually sit and listen to me. Okay. If just one person, I'll do it for just one person. There's two people. Okay. Yeah. And I don't mind doing it at all. I'm just like, oh, nobody. Three. Okay. So the implant PowerPoint is already up. And so I will go through and I'll talk through it and I'll kind of emphasize the things that are important for you guys to pay attention to. And then you'll just watch that on your free time between, now and, yeah. And then, And then as far as these activities go, fill them out based on based on what you can do it in groups. This is supposed to be in class activity, but we have 7 minutes at this point. So that will never happen. But so fill them out fully with, good answers and with your names on the top, and then you'll just turn them into me next class session. So 2 weeks from now, we'll turn them in. So let me just finish up. The main thing I want to say about rheumatic heart disease is that it's some people who have rheumatic fever, who get rheumatic fever, which can happen after strep throat, they can end up with some damage, some valvular heart damage. So if they have a bad enough case of rheumatic fever, they could end up with damage. So that would be rheumatic heart disease. Those people do not necessarily automatically have pre-medication. So just because they've ended up with some kind of a little bit of valvular damage does not, it used to be that we saw rheumatic fever, we get just like mitral valve prolapse, oh, give them pre-med, but not anymore. So that's one thing I just want to make very clear. You can read through these slides about it a little bit more, but that's the take home point, is that just because they have rheumatic, have had rheumatic fever or have rheumatic heart disease does not automatically make them pre-med. So you might consult with the physician, but otherwise, just because it's checked doesn't mean you give them pre-med. Infective endocarditis is basically when we call it infective, not bacterial, because there can be yeast, fungus, there's viruses, there's strep and staph. And so that's why they call it infective, not bacterial. And it's infection of the endocardium, the heart valves, and the cardiac prosthesis resulting in a microbial invasion. So basically, all the microbes kind of start to hang around a weak part of the heart and can make the person very, very, very sick. So a weak part might be like a completely defective heart valve or a replaced heart valve, like a prosthetic heart valve. So the risks, previous endocarditis, artificial heart valve, a serious congenital heart condition, or a heart transplant. So there's certain things that kind of warrant pre-med, but not nearly as many as there used to be. You want to identify your high-risk individuals from their health history. We want to make sure we're giving them the proper protocol for their antibiotic. Everybody gets a pre-rinse, so that's just everybody, but pre-procedural rinsing, that's to cut down the bacteria in their mouth for everything. So for bacteremias, for aerosol, it's just what we do for everyone now. Prevent unnecessary trauma to reduce severe bacteremia. So if someone has really bad perio, you're really getting in there reaming on the root, just try to still be aware of how heavy-handed you're being, even though it can be very exhausting and you can lose tactile sensitivity, but just remember how heavy-handed you're being and try not to do undue trauma to their gingiva. Help client maintain good oral hygiene and encourage regular care. This, just read through this. This talks about acute bacterial endocarditis as opposed to subacute. One comes on fast. Think of acute, like acute pain. Ow, it hurts now, really bad. As opposed to like subacute is like it's sort of easing in and a slower progression.
So do these patients, they do need to take pre-med or they don't?
Patients with like a valve, like a prosthetic valve or a defective heart valve or a heart transplant, those people do. If they have some kind of a very serious heart condition and the doctor has said they need it, then they need it too. Pre-med is one of those things where it can be like when it comes to patients who have a valvular defect or a prosthetic valve, they're just all sort of blanketed yes. But then there's other people that may be recommended pre-med, like a cancer patient may be recommended, or, like if their immune system is super compromised, so there's this kind of whole gray area of pre-med, but then there's like there's the sure people, and those people have valvular defects, significant valvular defects and prosthetic valves. And these couple others list here. These are people here who would these are patients here who would they're at risk for having IE, and these are patients that would have a pre-med. This is your group. So here we have the definite sort of outline of who would take a pre-med: previous, relapsed, or recurrent IE. Oh, that's group 2. So group 1, prosthetic cardiac valve or prosthetic material used for cardiac valve. That's your number 1 group. You see that on the med history, they need a pre-med. And then you have these other groups: recurrent, congenital heart disease, or cardiac transplant. So these are all the different groups, but this is the one that you'll probably see the most often, and you just know. And then these are the different medications. A lot of times it's amoxicillin, 2 grams of amoxicillin. But as we talked about, other people who might be allergic, if they have a penicillin allergy or something, these are the other regimens that are out there. Important to note that if somebody is having if someone has an SRP schedule, we always give them 9 to 14 days, so roughly 2 weeks. We always give them 2 weeks before we do the second half. And we just like to spread out that time between giving the pre-medication and multiple appointments. So that's just standard. So that can be a question on a quiz. How many days? So 9 to 14 is the standard for spreading out care for someone who has to take a pre-med if they have multiple appointments. And just read through these bullet points. These are all important information to know. But pre-procedural rinse, you're going to do it at everybody. Prevent unnecessary trauma. A lot of this is repetitive from the other slide, but highlight that 9 to 14 days. These are different types of surgeries. I'm not going to read through these at all. This is sort of like nice to know, not need to know, but obviously, again, it's highlighting the valvular defect must be pre-medicated. These are oral manifestations of cardiac medicines. These are all things you may see for various medications. And then for an even better detailed list, I have all of these medications for different, kind of tells you here: congestive heart failure, atrial fibrillation, congestive heart failure, hypertension, angina, hypertension, and then the oral implications. So there's several slides here that go over all of that. So that's really nicely laid out. And I think that might have come straight from, I can't remember if that came from Oral Med or not, but it's a good review for the generic names. So who didn't pick up one of these? I think everyone should have one for implants and one for cardiovascular. So who didn't get one? There's one. And then somebody didn't get. You didn't get that. Did you get the implant one? There you go. So fill those out. Make sure your name's on both of them unless you staple them together. Fill those out and hand those back in next class. And then I will post a recording of the implant. And that one is not so kind of mind stressful. Implants are kind of like, oh, I'll see an implant, and it's like if someone has a denture. You know, there's one thing you got to know. You got to know a set of certain things, and it's not as stressful to try and remember the stuff about implants as cardiovascular. Cardiovascular is a lot. So just like I said, make a table, and then that can help as well. And then just those activities, you guys can work on them together. You can answer them, but just make sure you turn them back in next time we meet in 2 weeks. All right. So sorry. I'm so sorry I was late, you guys. I'm taking my key out of my ignition from now on. Have a good rest of your day. Yeah. Oh. Yeah. Because you are the correct answers. You're always expected to know all the benefits, but we'll test you on them. Likely not unless it's very specific, like you never like this. But this stat will come up on its board in spreadsheet. So if it's something very specific, like diagnostic or a longer, or a lot of them treat saliva. Well, a lot of them is common, but if it's something that's very specific, that is very
Yeah. Like, I mean, like, most people can take from us the billing cancer. That they clear kind of like. So, and so.
Yes.
For the implant,